So guys, hope I'm audible and visible. If so, say me hi. Okay, I hope I'm audible and visible. Fine. Okay, hi Vinay. So welcome back once again. So we are in the second module of the respiratory system chapter. Like yesterday, we saw the basics, the pneumonia. Good evening, Atul. This ARDS, a little bit about COPD, and the basics histology of the lung parenchyma. Right. So today we'll be continuing with the same thing. We'll kind of start with from wherever we left yesterday at COPD, the emphysema. Good evening, Sajid. And we'll be looking at chronic bronchitis today. Good evening, Tabasa. And also we'll look at your restrictive lung disorders. COPD is one type of lung pneumoconiosis. We'll look at them. Then you look at your tumors of the lung, which is also an important topic in your curriculum wise. And also look at tuberculosis. Because I have taught you about the pathogens of tuberculosis, but in total about tuberculosis, how it comes, how it arrives, the primary, secondary, tertiary forms of tuberculosis, we're not discussed. We'll also look at that, right? So let's start. Okay, so we're going to go with the same thing in COPD spectrum, the chronic bronchitis, right? So chronic bronchitis, the per se, the by definition, chronic bronchitis. Yeah, which one, Sajad? Pathogens of TB I did in chronic inflammation. That is the same pathogen as how a granuloma is formed. That is the same pathogens for tuberculosis as well, right? We can write that for any tuberculosis wherever it's asked. Okay. Okay. Let's come back to this. Chronic bronchitis is a diagnosis made on clinical examination. It's not a microscopic diagnosis, but though there are few defining findings in microscopy, which comes in an exam as in a viva test, right? Chronic bronchitis, by definition, it's cough with sputum production. It will be written expectoration. Expectoration means sputum production, right? And it should be there for at least, I should have for 3 months, continuously for 3 months, and 2 consecutive years. This is by definition chronic bronchitis. If I have something of this, I can brand the person's having chronic bronchitis, right? The most important thing, the definitions are actually not medical definitions. When you go to any definitions in the entire medical curriculum, they are legal terminologies. They're not medical terminologies at all. Because you can diagnose chronic bronchitis by looking at the patient, the quality of the cough, you can diagnose chronic bronchitis, right? But these are definitions as per the legal criteria. So in most of the definition, you'll be having a bracket, you'll be having a caveat. It will say that here's in the absence of any other disease. This is the most dangerous terminology ever, right? Any other identifiable cause. Okay? This is difficult. You cannot rule out every cause in the textbook saying that, okay, I have ruled out everything, so I'm having a patient with chronic bronchitis. It's impossible to rule out at any point of time. Even if you are in your Massachusetts, Boston, any top level institutions in the world, you'll not be able to do it at all, right? So if you have any definition, if you encounter it says like rule out all other causes, please write the term differential diagnosis. This is very, very important. Like I said, this is not for an MCQ. This is not for your university exam. This is for you when you come to practice. It's always DD. DD is differential diagnosis. Okay, I'm sure you must have read about dengue fever, right? See, I'll tell also with emphysema very soon. Fine. I'm sure you must have heard about dengue fever, right? You must have heard about dengue fever. Can you identify dengue or malaria or typhoid clinically? Possible, not possible? Not possible. You cannot. Clinically, I can say it's a fever, most likely viral onset. I will not be able to say it's dengue. Unless and until I have a lab evidence saying that dengue antibody is positive, I cannot call it dengue fever clinically. So I say differential diagnosis fever, query dengue, that's all. Again, query malaria. I can suspect malaria clinically. I cannot legally, I cannot diagnose any of them without a lab finding. Tuberculosis, I can suspect. Unless there's Mycobacterium tuberculosis seen by PCR or by microscopy, you cannot say it's a tuberculosis or a culture positive, right? So whatever it's come, please use this term judicially because this is going to help you in long term. Now itself, you start using the term, okay, DD, differential diagnosis, not a diagnosis. That makes much easier thing, right? See, it might be associated with emphysema for sure because for both of them, the primary etiology for us is smoking. Smoking is the primary etiology for bronchitis. smoking, if can attack the bronchus, it can also go and attack my alveoli causing emphysema, because bronchitis, the site of destruction is the bronchus. Emphysema, the site of destruction is the arsenic. Fine. It can be associated with many other findings. You can have hypoxemia, you can have respiratory failure. Those are all additional pointers here, right? Let's come to the pathogenesis. The pathogenesis here, it's a destruction, that's all right. Like I said, my predominant risk factor for me is smoking. Smoking is undoubtedly the important cause, the most common cause of bronchitis as well. Chronic bronchitis is almost equivalent to say the patient is having a smoking. That's all, smoking related dysfunction. So here, the smoke is going to, the particles of the smoke will cause damage to the cilia, damage my respiratory epithelium. It will obviously damage the respiratory epithelium. Obviously it will, right? I'm sure you must have walked into an area or a room with full of smoke. When you walk into a room or an road with full of smoke, what is your first response? How will you respond? Anywhere you have smoke, how will you respond? What's the response? You go into a room full of smoke, what's your first response? Or a lorry passes with having lots of smoke, what's the first response? Cough. You will cough for sure. You'll cough and you'll spit. That's how it is. When you cough, this damages the epithelium will by reflex produce mucus. That's a protective mechanism. The protective mechanism is very simple. Some dirt is coming into the cilia. My cilia cannot push it alone without the absence of mucus. It produces mucus and the dirt is attached to the mucus, and then my cilia pushes it outside so that I can spit it outside. That's the response. Imagine persons who are smokers are consistently there in the environment, almost always having problems here. Every single time person smokes, reflex is going to happen. So what do you think will happen to the mucus glands on a long term? Will it become bigger, more in number, or smaller? What do you think will happen? It will definitely become more in number, right? So can I call this hyperplasia? Can I call this an adaptive response? I definitely can call it an adaptive response, right? Before metaplasia, hyperplasia is important for me, right? There's a mucus gland hyperplasia because normal submucous also has mucus. Here it's having more mucus production. That's all, right? So predominant thing for me is smoking. I can have few rare contributing factors. These are not my diagnostic factors. If there's a patient that's having cystic fibrosis, in cystic fibrosis, the mucus is going to be very, very thick. When there's thick mucus, the particles get stuck there and can irritate for a longer time. It's not very fluid, right? You can have other associated infections. Again, these are all just contributing factors. They're not the etiology. They contribute. Because only infection can never cause chronic bronchitis in the absence of tobacco smoke. Tobacco smoke is undoubtedly the cause. These all can definitely add on to it, right? So any infection, inflammation, these do contribute. So when you have a damage to the epithelium, this epithelium will protect itself. That's how it happens. So it results in increase in the, like you guys said, mucus secretion. Mucus hypersecretion is one of the findings seen in case of chronic bronchitis. That's why the patient's having cough with sputum production. Expectoration is very, very important in case of chronic bronchitis, right? So who causes mucus secretion is increase in the number of glands. It's primarily increase in the number of glands, bronchial mucosal gland hyperplasia, plus or minus, you can have your hypertrophy. Hypertrophy is not that important for me, but yes, I might have hypertrophy. That's very, very less important for me, right? Cigarette smoke predisposed to chronic bronchitis. That's the most important thing here, right? So this is what's going to happen. This, if it happens, definitely the patient will have expectoration whenever the person is going to cough, right? So now tell me, if the person stops smoking today, will this process reverse? Will there be a reversal? Can they reverse? It will reverse, right? Because this is an hyperplasia. Every hyperplasia is reversible, but stopping smoking is the most difficult part to happen. If the person stops smoking, every process will reverse because this is nothing but hyperplasia. It's an adaptive response. That's all, right? Now let's see what will happen to the gross appearance. Though gross appearance is not required for me, you are going to tell me plus or minus, with or without. That's what I meant by plus or minus. Fine. Okay. Hyperplasia is very important. Hypertrophy may be there, may not be there. Okay. So you tell me, what do you think will happen to the mucosa? See, everything you're going to tell because you know a decent amount of pathology. You can easily imagine what will happen. It's an inflamed mucosa. Will it be red in color or will it be pale? Will there be swelling, edema? Will that happen? Yes or no? It will be, right. Instead of calling it red in color, use term hyperemia. That's all. It's hyperemic. It will be swollen. A swollen mucous membrane with mucus secretion. you can easily predict how it will look. If I'm going to look at the mucosa, it will be hyperemic, it will be red in color with swollen, and it will have mucus production for sure. Is there a possibility this mucus production, ideally I should spit it outside? Is there a possibility this mucus can drip down and can go and plug tiny bronchioles? Is there a possibility? Yes, no. There might be a possibility, right? Most of the time the mucus is going to be secreted outside. At the same time, this mucus secretion, if it's in excess, not able to spit it outside, so retains for some time, this can block the tiny bronchioles. Okay, now just imagine I'm just going to lead to a complication, let's assume. So I'm having the main stem bronchus like this. We have the divided bronchi and divided and subdivided into multiple tiny bronchi, subdivided into multiple tiny bronchi, right? So here is where the irritation happens. Let's assume red in color. So saying it's hyperemic, right? So from this, slowly the mucus went downstream and kind of blocked this area. Okay? It's a mucus plug blocked here. So is there a possibility, I'm saying, distal to this, distal to wherever the mucus plug's blocking, the cilia will not be able to function properly? Yes, possible. Because my mucus plug is blocked here, will the cilia be able to function properly distal to it? It might not be, because it's not be able to move it. If the cilia is not functioning properly, is there a chance I can have infection here? In this part, I can have a mucus plug and I can have infection. If I'm going to have an infection, again, it will slowly, when there's more and more infection, more and more an inflammatory response. Can the inflammation destroy the bronchial wall? Can it? It may or may not, right? Possible? Yes. If the bronchial wall is destroyed, that's what results in ectatic dilatation. What do we call the term? So when the mucus plug blocks, there might be infection here. This infection in turn causing the WBCs to come. This might destroy the bronchial wall. When it destroys the bronchial wall, in a long term, we call it bronchiectasis, ectasia. It becomes dilated. When it becomes dilated, more pooling of mucin, more infection. It's a vicious phenomenon. It keeps on happening the same thing. This can happen, not always. Always it will be expectation. Sometimes this possibility is also there, right? Now, let's come to the microscopy. We are going to understand the microscopy. There's one component called as Reed's index. Reed's index no one uses these days to diagnose chronic bronchitis, but unfortunately, quite a few exams ask Reed's index, and I'm sure in Viva they'll ask you Reed's index, right? For understanding Reed's, let's understand how will a normal bronchial mucosa look like, a normal bronchial wall. What is the lining epithelium of bronchus? What's the lining epithelium of bronchus? Lining epithelium, pseudostratified ciliated columnar epithelium, right? So I have a lining epithelium here, a pseudostratified ciliated columnar epithelium. Below that, you have your submucosal glands. I'm saying just normal thing. Below the submucosal glands, you have a muscle layer. Bronchus will have muscle. They do contract, right? Below that, you have cartilage. That's how the organization of bronchial mucosa is. You have cartilage. There's an entire bronchial wall. Pseudocertified ciliated columnar epithelium is the normal lining. It's not squamous, right? When it becomes problematic, it becomes squamous, right? Okay. Now, this person is going to have smoking. The person is going to smoke. The person smokes for years together. Like we read, the mucous glands will become more and more thicker, right? So my epithelium is here, same. My mucous gland becomes like 4-5 layers. Normally, like I said, 2 layers is the normal layering of your mucous epithelium. Here it becomes more, becomes 4-5 layers, right? And let's say you have the muscle here, stays the same. Cartilage will not alter, right? It's not going to alter much. Cartilage also stays the same. Now here, this is mucous gland hyperplasia or mucous gland hypertrophy. The mucous cell layers or the mucous glands will definitely undergo increase in thickness. So instead of calling it hyperplastic or increased thickness, we want to give an objective terminology. Because like if I give you 2 images, 2 of you are seeing the mucous glands, some of them will say only 2 layers are there. Some might say no, 3 layers are there. Why to have a confusion? When I make it objective, there's no confusion. Yes, no, that's all, right? That's where we had a terminology called as Reed's index. Okay? Reed's index can come in exam. Do remember. We'll see what does Reed's index mean, and we'll see how to calculate Reed's index soon, right? Reed's index is nothing but the thickness of the mucus layer. Let's assume this part. Okay, let's keep this A. That's the thickness of the mucus layer, right? Second is thickness between the epithelium and the cartilage. Let's say this is the second part. Epithelium, cartilage. Okay, this is the second part, right? I'll just zooming this here. The first A is thickness of the mucus gland layer. Just give me a second, Sajad. And the second thing is the calculation is from the epithelium till the cartilage. I'm calculating the whole thing, right? So let's say normally Reed's index is nothing but it's mucus gland thickness or the mucus layer thickness divided by epithelium till cartilage. Okay. The normal Reed's index is 0.4. What do I mean by 0.4 here is in a normal wall of the bronchus, 40% will be mucus gland thickness. That's all. Rest everything is made of your epithelium, muscle, cartilage, and the submucosal layers, right? 40% of the normal, everyone's normal mucus, your bronchial will be made of your mucus glands. That's all. Here, in case of chronic bronchitis, what do you think will happen to your mucus glands layer? It will become more. So, what do you think will happen to Reach index? It will be more than 0.4 or less than 0.4? It will definitely be more than 0.4, right? So, there will be more than 0.4 because my numerator increases, it will be increased. Reach index, when it becomes more than 0.4, I can say for sure I'm having a mucus gland hyperplasia here, right? Perfect. I'm asking you a different question. Is Reach index particular or specific for chronic bronchitis, or can I say a patient who's having asthma? Will asthma also have mucus secretion? More? Can have, right? A patient with asthma also, will there be more Reach index? There'll be. Bronchiectasis, there'll be, right? So Reach index is not a specific finding for chronic bronchitis alone. It was discovered in chronic bronchitis. Any chronic disorder which increases the thickness of bronchial mucous glands will definitely increase in your Reach index. So then coming back to your question, the person is going to smoke irrespective of wherever whether there's a blockage or no blockage, doesn't matter for me. Wherever the person is having the smoke exposure, that mucosa will respond by increasing the thickness. Blocking of them is generally due to mucus plugging. Not see, my mucosa will not become so big to block. Mucosa is bigger. Still, I'll have lumen. The mucus becomes very thick, plugs them, right? So, Reach index will be uniformly increasing in any patient with chronic bronchitis, right? Like I said, this is of theoretical importance. No one is going to take a biopsy for chronic bronchitis. How do you identify a smoker? How do you identify a patient who is a smoker? Smoker means with your cough and expectoration, we call them chronic bronchitis. That's how we do it, right? And most of the time, we don't identify smoker at all. We look at the patient's lips, we say, okay, smoker. Please don't judge people. You hate when your parents judge you, right? So when you become a doctor, you will have lots of judgment to make, but I don't want to judge people looking at the person. Ask history, right? Ask history. If the person is a smoker, they'll say, yes, I'm a smoker. The reason why I'm saying is black lips can be a sign of smoking in abroad, Caucasian population, where the entire color is white. For India, we are brown people. So blacker lips could be just a complexion, just normal in Indian culture, right? So don't judge people. Ask them what it is. If the person is a smoker, they will tell you it's a smoker. Talk to 5 more minutes. They will say, do you want a cigarette, sir? That's how welcoming they are, right? So don't judge people. Ask for history, which there. Please document them, right? And look at this image. Can I call this glands? They are glands, right? I'm sure you will accept that the number of glands is more than 2 layers easily. This entire thickness here is glands, right? I'm going to have mucus, that's much amount of mucus gland hyperplasia you'll see in case of chronic bronchitis. But like I said, if I'm going to take a biopsy for chronic bronchitis, it needs to make some sense. I'm not going to look at Reach index in biopsy because I know when the person spits out cough or sputum, I will know that mucus glands is more. It's a response, that's all, right? What is more important in this image more than my mucus gland hyperplasia? There's one thing which is more important than mucus gland hyperplasia. What is that? What do you think is more important in this image than mucus gland hyperplasia? I'll come to Tabasum. What's more important for me is this. We just now learned that the normal epithelium is pseudostratified ciliated columnar epithelium, right? So can I say this epithelium, this side of the epithelium, is it stratified or pseudo-stratified? What do you think it is? Stratified or pseudo-stratified? It's definitely multiple layers, right? It's multiple layer, it's thicker. So what's happening here? What is happening in this area? You're having metaplasia. Okay? You're having metaplasia. It's a metaplastic change. That's very, very important here. I don't take a biopsy to see Reed's index. I take a biopsy if the patient is having a squamous metaplasia. If the patient is having a squamous metaplasia, what is the probability? What can the patient develop next? What can the patient develop next? The patient can have dysplasia. This patient can end up in having a carcinoma, right? That's our major concern, nothing else. Okay, perfect. This is the reason for your biopsy. Generally, this might not happen. The reason I'm saying it might not happen is, let's say you will definitely accept, maybe you are from a polluted part of India. Most of the India is polluted, most of the world is polluted for the matter, right? One of the worst polluted states is Beijing in China, right? So if I'm going to live in there also, I am not going to inhale each and every second the amount of particles like a smoke. When I smoke, the density is more important. When I breathe, yes, I have normal air. When I have a polluted air, I close my nose, right? Or I put a mask. Right? That is something which will not happen. Reindex will not happen when you have a patient who is living in a polluted environment, right? Okay. Atul, how you want to know how metaplasia in the microscopy, or you want to know how metaplasia happened here? The reason for metaplasia is the first chapter. In the first chapter, we read about when there's smoking. Smoking goes and destroys my ciliated epithelium in your bronchial mucosa. When there's a bronchial mucosa which is having a ciliated epithelium, in order to protect the ciliated epithelium being destroyed, I make them squamous, because squamous is more resistant to smoke. Skin, nothing happens to skin due to smoke, right? Okay, in microscopy, how do I know is, okay, look at this part. Okay, this is a very low power image, right? Look at this part. Now tell me, this part, whatever I put a circle, you think it's single layer or multiple layers? Atul, what do you think? It's a single layer in this end or multiple layer? Single layer, right? I'm sure you'll accept that this epithelium here is definitely a single layer epithelium. Now, the same way, just go through across it. Can you see that epithelium is becoming thicker and thicker and thicker and thicker? Yes, in this corner, it's multi-layered. So from a pseudo-stratified, that's a single layer epithelium, it's becoming stratified. Columnar epithelium is not stratified. Squamous epithelium is stratified, right? So that's what happening here. It's become multiple, it's become stratified, right? So I hope you'll be able to understand. Just compare. You can easily identify it's normal or abnormal, right? Perfect. Okay. That's about chronic bronchitis, right? Next, let's go to restrictive lung disorders. The restrictive lung disorders is a huge um, chapter on its own. And when you go to medicine, you'll learn more and more about restrictive lung disorders. In pathology, I'm not going to concentrate much on restrictive lung disorder. One part which is supposed to be there in detail as per your curriculum, we'll definitely cover them. And we'll also see what does restrictive lung disorder in general means, right? The restrictive lung disorders, like the name says, the first was obstructive, COPD, chronic obstructive pulmonary disorder. It's restricting. So where do you think is the problem? The problem is in the lung obstruction or the lungs function, that let's say the rib cage is not allowing the lung to expand. Where do you think is the problem? And the problem is in the air gate section, or it's not letting me to expand. It's not letting us to expand, right? Like we saw in ARDS, the second stage, alveoli was normal. It was not letting them to expand, right? So if I'm having an expansion problem, I can have multiple expansion problem, right? Let's go and slowly classify the restrictive lung disorders, or we also call them chronic interstitial lung diseases, right? So we divide them into major groups. It can be due to the lung problem. I can have chronic interstitial lung disorder. Under this, we'll have subclassification. I'll go into them soon. Hydrothorax, possible, right? If it's a very big pneumothorax, hydrothorax, or a pleural effusion, possible, right? Second biggest probability for me is your problems in the chest wall. With chest wall disorders, nothing related to the lung, but still chest wall disorder can cause this. I'll just ask you a simple question. If a patient is having poliomyelitis affecting the leg muscles, the person cannot walk properly, right? If the person is not walking properly because of muscle involvement in the leg, if the muscle of the rib cage is involved, the intercostal muscles, will the patient be able to breathe properly? Might not be, right? So when I say chest wall disorder, it could be neuromuscular, not just poliomyelitis. You must have heard about a disease called as Duchenne's muscular dystrophy, right? I'll answer your question, Sajad. Neuromuscular disorder or anything which is causing a muscle weakness will definitely not let my rib cage expand properly. Your respiration will definitely be difficult. No problem in the lung, but expansion, the accessory muscles of respiration not working here, right? Second, like Tabasam said, it could be a pleural disease. There's no problem in the lung. I'm having such a big effusion. Lung is not able to expand. Or a pneumothorax, not able to expand. Possible, right? Or it could be problems in the spine. Do you know, have you heard about any term called as kyphosis or kyphoscoliosis? Have you heard about them? Have you heard about this? You must have heard in your anatomy when you read about spine. Kyphoscoliosis is twisted. Scoliosis, is spine is not straight. It's the form of a S, scoliosis, right? So the vertebra is not normal. The bones are coming from the rib cage is coming from the vertebra. When the vertebra is abnormal, rib cage orientation will be abnormal. Again, expansion will be a problem. Last but not the least, obese. If the person is extremely obese, not normal thing, extremes of obesity, again I'll have a problem here, right? So all these are not lung disorders, but will indirectly affect the expansion of lung. Fine. Okay, Sajad, emphysema happens due to direct exposure of the smoke particles to the lung parenchyma, right? If the mother is a smoker, the smoke does not reach the baby. Smoke particles gets dissolved in the blood, right? Because baby is not going to breathe at all. Lungs are inactive inside the uterus, so you won't have a problem. But when the mother smokes, there are some other problem. You might have end up in abortion, IUGR, because smoking will cause problems in the arteries. We read about your thromboangiitis obliterans. That might be a problem. Emphysema might not be a problem. Fine. Okay. Let's come to lung pertaining disorder. Lung pertaining disorder. We divide lung pertaining disorder into fibrosing disorder. So there's a longer thing which is over the period of time increasing in number. So one of the major disorders is just interstitial lung disease. You will read about interstitial lung disease when you come to medicine. It's diagnosed based on HRCT. There's very little contribution to microscopy, right? Then you have your granulomatous lung disease. Anything granulomatous. It could be tuberculosis, it could be an infectious disorder, anything granulomatous again can destroy it. Ribs are part of a chest wall. Kyphoscoliosis includes a rib disorder as well, right? They are. Anything problem in the bone, muscle, or the soft tissue or the pleura, I'll have a problem. Fine. Okay. Third, again, the fibrosing lung disorder is where we have your thing what we're going to read next, pneumoconiosis. Okay. It also causes fibrosis. Fine. Then I have something which is smoking related disorder. There are few classical smoking associated disorder which also will not let my lung expand, and then few rare findings like LCH, Langerhans histiocytosis, and few rare types of pneumonia which can also happen, right? So our main focus, what's there in your curriculum, is your pneumoconiosis. We have to read in detail about pneumoconiosis, few names, few particular manifestations, few MCQs, and few clinical importance. See, you were not required to learn much about the pathogens of this because it's something which is going to impact and very severely, and the pulmonologist will take care of that. Your curriculum, what's made for you, is very, very good. The reason why, though pneumoconiosis are rare, the reason why a young MBBS doctor should know about pneumoconiosis, when you finish your MBBS, there are lots of work opportunities available. One of the work opportunities, industrial medicine. You go in industries, any like Tata is there, Jamshedpur Tata is there, right? Those industries will have an in-house doctor, a team of doctors. The role of those doctors is to have a monitoring, regular monitoring of all the employees, or in coal mining industries. You need to be there because only you are going to tell, see, this patient is having a lung disease due to coal. Give them a leave. You have to sign them. So that's why an MBBS doctor is required. I cannot appoint a pulmonologist in every factory. but I can appoint an MBBS doctor in every fact, right? So whatever whoever created the CBMA curriculum has thought through it properly, and I hope it will be followed as well properly in the future. Fine. Let's go to pneumoconiosis. Let's see why I having a problem of pneumoconiosis and what is the main determining factor. There are multiple determining factors. There are few things, uh, multiple factors which affect the pathogenesis. One of the important factor for me is particle size. So there are dust retention, right? So the concentration, that's what Tabasam said. The concentration is more important. When I'm having a polluted air, it's not a problem for me. Carbon is there here also. But when I'm working in a coal mining, the retention is very, very high, right? Yes, this is otherwise known as occupational lung disorder, fine. So dust retention is important. When I say dust retention, it talks about the concentration of whatever particle is, coal or whatever it is in the air, right? The concentration is more important, not just the presence. Second most important thing for me is particle size. We'll talk about particle size in detail because that's the most important determining factor. Not just that, particle solubility. If a particle is very soluble, right? If a particle is very soluble, it might not cause a chronic lung damage. It may cause an acute lung damage. The particle is not soluble, staying in the alveoli for a longer time. That's what is going to go and slowly destroy and result in fibrosis, right? So it's not just the particle size, particle solubility is also important. When a particle is less soluble, this has more chance of staying in the lung and results in a chronic problem. It stays there for a longer time, that's all. If it's soluble, it may cause an acute damage or it can escape outside, right? Next, these are few important things, and also the capacity to activate inflammation. They have to trigger inflammation. If something is trigger my macrophage, only then all these problems will happen, right? The most important determining factor, like I said, it's particle size. I'll tell about particle size, what is there in Robbins. When you go to your PSM, Park has a different particle size strategy. I don't know which is right. Both are good books, so I will not be able to say which is right, which is wrong. But I'll say whatever Robbins says. If you have a particle size of less than 1 micron, this particle will reach the alveoli. From the alveoli, it goes into the blood. If it's going into the blood, do you think it will cause pneumoconiosis? I mean, a particle, it's going into the blood. Do you think it will cause pneumoconiosis? No, it won't, right? It's not going to be there in the lung at all, right? When you have a particle more than 5 micron, this will be caught up in the cilia. The cilia will be catching them. I'll spit it outside. Again, I don't have a problem. The dangerous particle is 1 to 5 micron. These are the danger size particle. These particles are going to stay in the alveoli. They reach the alveoli because my cilia cannot pick them up, and they don't go outside also into the blood because they are bigger. They cannot escape into the alveoli, right? So these are the danger particles. My concern is when a particle, these danger particle stays in the alveoli, there's one person in the alveoli who's going to eat everything. Who's that? That's your macrophage, right? So pathogenesis of every pneumoconiosis is the same thing, whatever I'm going to say. Macrophage goes and eats the particle. That's what every macrophage will do. Something foreign come and eats. Do you think, let's take an example of coal. Do you think your macrophage can destroy a coal particle or it cannot? What's your take? Can a macrophage destroy coal particle? It can't. Coal is already destroyed, right? It's a dead particle, but my macrophage doesn't know that. It will try to damage it, it will try to break it. It cannot do it. So if a macrophage cannot destroy something, what happens? Inflammation chapter. My macrophage is not able to destroy my tuberculous bacilli. So what did they do? Macrophages are also antigen presenting cells. They gave the antigen to my T cells. T cells activated. The same story happens. When macrophages can't destroy, they result in granuloma formation. Now you're going to tell me, let's see how good you are. This granuloma form will be necrotizing granuloma or non-necrotizing granuloma. You know the basic difference between necrotizing and non-necrotizing. If you remember them, this is necrotizing granuloma or non-necrotizing. This is non-necrotizing, and it's not necrotizing. The basic difference which I told while classifying granuloma is, if you feel my macrophage can destroy them and kill them, it'll cause necrotizing granuloma, tuberculosis. You cannot destroy coal, you cannot kill asbestos, you can't do anything to silica, it's already dead. So it'll be non-necrotizing granuloma, right? Now here, we didn't classify them under granulomatous disorder. We classified them under fibrosing disorder. The reason is, a person working in a coal industry, once the granuloma is formed, will there be more and more and more inhalation of coal particle? Will be, right. So it will not end here. The pathogenesis will automatically repeat, and any chronic inflammation, the final form is definitely TDHF, tissue destruction healing by fibrosis. It will end up in fibrosis for sure. It will never stop here. It keeps on going. It will definitely end up in fibrosis for sure. Fine. Okay. This is what happens in case of every pneumoconiosis. I will not repeat this. When you have a question of silicosis, few pneumoconiosis which is required for us. Other few things I'll just name them. There are few things which I want you to know: coal workers, silicosis, and asbestosis. Right? Coal workers pneumoconiosis. Any question which comes in exam, microscopy more or less same. There are few findings. Clinical symptom more or less same. What will help you to define them is, like Sajad said, they are all called as occupational lung disorder. So occupation tells me whether the problem is silica exposure or coal exposure or asbestos exposure, right? So occupation is more important. A coal miner. If you are working in an environment which is polluted, you will not have anything. Only when you have a coal miner, especially there are two types of coal, hard and soft. Hard coal miners will have more and more chance of coal workers pneumoconiosis than other things, right? So in coals, there are actually two different types of coal. One is called an anthracite coal. The other is called as bituminous coal. These are the coal types, right? Okay. Bituminous coal. Anthracite coal is what we use in coal mining. Right? The coal mining is where we produce electricity from, right? So anthracite coal is seen in coal mining. Anthracite coal causes coal workers pneumoconiosis on exposure. Bituminous coal is not seen in coal mining. It's seen in firewood burning. When you burn a firewood, right, you have bituminous coal. The initial part of the coal which comes is going to be bituminous coal. So there is no increase in risk of coal workers pneumoconiosis. This will not cause coal workers pneumoconiosis. But the biggest problem here is this might cause cancer. This coal is more notorious than my coal workers pneumoconiosis coal. Here, there's no increase in risk of cancer. Yes, it will cause a lung problem. It will not cause cancer for me, right? That's something good for us. If I can monitor them and I can save the patient, it's more than enough for me, right? So firewood, when you bituminous, BITU, okay, it's bituminous coal. So firewood cooking will definitely increase the risk of your cancer. That's why my government is trying so hard to make my entire country have liquefied petroleum gas, LPG, cylinders. Because we were cooking with firewood, then kerosene, then LPG. So firewood undoubtedly will increase the risk of lung cancer, especially in a small home where there's less ventilation. The air keeps on circulating in the same place you have this, right? So my government makes amazing steps, very slow and tiny progression. But human beings, we are the weirdest bunch of species in the entire planet. I grow 2 steps, I go back 10 steps. We made the entire government did so much of difficulty pushing LPG gases. And what we are eating? Barbecue foods. What is barbecue? What is barbecue? Barbecue is cold, right? It's smoked food. When you eat barbecue food, it will result in stomach cancer. It will result in colon cancer. Barbecue food is a grade 1 carcinogen. Grade 1 carcinogen means it's definitely linked with cancer production. Don't worry, you won't have stomach cancer or colon cancer. Thank goodness barbecue foods are expensive. Right? It's expensive, so we don't eat every day. Whenever a friend gets treat, you go and eat barbecue, right? So anything you barbecue it, right, it'll result in a, for sure, it'll increase the risk of cancer. I'm not saying you'll have cancer, but definitely increases the risk compared to a normal population, right? Okay. So don't eat on a daily basis. Daily basis will definitely cause a problem. Such as these are I'm when I'm talking about cancer here, I'm talking about lung cancer, right? I don't have a problem with lung cancer if it's going to get absorbed in the blood. If it's going to damage my lung epithelium, yes, it causes lung cancer. So whatever we are talking about pneumoconiosis and cancer, it's related to the same thing which stays in the alveoli, fine. Okay. But keep in mind, anything which is black in color on the outer aspect, be it paneer, be it chicken, whatever it is, everything will cause has a risk of cancer for sure, right? So don't eat on keep on eating everything barbecue foods, and we cannot use electric barbecue. We use coal barbecue only, right? Now let's come back to this. We have anthracosis, simple coal workers pneumoconiosis, CWP is coal workers pneumoconiosis, and complicated. For all of them, we need to know gross, microscopy, and lung function. If we know this, that's more than enough. Anthracosis is not occupational. You and me will have anthracosis, right? This is seen in most of the people who live in urban cities or who smoke. It's just not a occupational lung disease. Anthracosis will never progress to simple coal workers pneumoconiosis unless and until the person is working in a coal mining industry. These both are occupational disorder. The pure coal workers pneumoconiosis, they are occupational only. Right? Anthracosis grossly maximum allows black spots. There'll be black spots in the lungs. No granuloma, nothing, just spots. Your lung will have black spots, my lung also will have black spots, right? So here, and look at the microscopy of anthracosis, what we'll see in here is, you'll be seeing pigmented macrophages. You'll just see pigmented macrophages, nothing else. You'll have macrophages with pigment. Again, no granuloma. I do inhale coal, but not in that concentration. It will reach my lung. My macrophage will eat and will not get triggered. It'll just keep quiet. That's all. Eat and store them. That's it. Fine. Maybe it can go to the hilar lymph node, black color hilar lymph node. It will not cause a granuloma at all. When there's no granuloma, do you think there'll be tissue destruction? No, right? Do you think lung function will be altered? No, right? Lung function will be absolutely normal. Your lung function, my lung is completely normal, right? I do have a anthracosis. That's not a problem at all. When it comes to coal workers pneumoconiosis, I will have troubles here. Yes, Atul. Anthracosis is a finding seen for every individual in India or in any polluted nation for that matter. Most of the nations are polluted, right? So it's an environmental problem. It's not an occupational problem. And it's not a disease, it's a finding. That's all, right? As simple as that. Coal workers pneumoconiosis is an occupational lung disease, right? It happens only in coal miners. Simple coal workers pneumoconiosis grossly have 0.1 to 1 centimeter nodules. This can be seen on an X-ray. If you do an X-ray, I can easily see them. In microscopy, this will have non-necrotizing granuloma. If I'm having a granuloma, will there be an altered lung function or completely normal? You will have altered lung function for sure. It will be altered. It's granuloma. Granuloma is reversible or irreversible? What do you think? TB had granuloma. Is reversible or irreversible? It's reversible, right? Altered but reversible. This is where we come into play. There is something called as Factories Act. There's a rule for every factory, for a coal mining factory, once in 6 months to a year, based on the duration of occupation, you have to take a chest X-ray. When you take a chest X-ray, let's say there's a 0.5 centimeter nodule in the chest X-ray. The doctor will tell this patient might be starting to develop simple coal workers pneumoconiosis. Give a paid leave for 4 months. No exposure to coal for next 4 months. I'm just assuming 4 months randomly. After 4 months, again repeat the next day. If everything is resolved, come back to work. That's how things work. We have a very, very good Factories Act that sometimes or most of the times not being followed. That's unfortunate, right? But medicine has been perfectly working with science to your political science to create amazing acts. It has to be followed. That's in the hands of human beings, right? Because if I follow it strictly, The next stage will never happen. I find the problem, stop the problem, reverse it, and then after some months, few months or years, go and start working again, right? So because if I miss it here, here it produce 1 to 10 centimeter lesions. Obviously, it can be picked up on X-ray, and microscopy here, it will be fibrosis. The other name for complicated pneumoconiosis is progressive massive fibrosis. Progressive, complete lung can be fibrosed. It's fibrosis. Do you think reversible or irreversible? Here also lung function is altered. Obviously, there's no doubt, but it's irreversible. Fibrosis. When it comes to the third stage, even if the person stops working, lung will fail. Patient will have lung failure, patient lung will fail. Secondary to that, you'll have heart failure, results in corporal net, everything will happen, right? Ideally, the third stage should not happen if my factory act is working properly. I hope it will work properly in future and will not move to the third stage, right? Because science says when it's granuloma, tiny nodule, it's reversible. This might be applicable in different factories. I'm just giving you a template. For different things, I'll have different points to identify, give rest, and come back to normal, right? So this is about coal workers pneumoconiosis. It might cause lung failure. It will not cause lung cancer. It will never increase the risk of lung cancer. Documented, it will not increase the risk of lung cancer for sure. If the person smokes, it will increase. But coal is not going to cause lung cancer. Right? Then image from Robbins. The easiest way to identify coal workers pneumoconiosis. Don't look at granulomas at all. Color. Don't say that I'm seeing fibrosis, I'm seeing granuloma. Black color coal, as simple as that. Silica will have a different finding. I'll tell you the finding. Asbestos will have a different finding, right? It's carbon particles. That's all. It's black in color, right? This is the black color. Anthracose also will have the black color. Silico, the simple also will have the black color. Massive, progressive massive fibrosis will have black color with fibrosis like this. These are all fibrosing area. It's destroyed completely, right? Black color is a clue for me to diagnose any lung biopsy with black pigments. Look for either of these three in the options. That should be the answer, right? Based on reversible nature, irreversible nature, and lung function being affected, not affected, you can give a call, right? Okay. So the next one, silicosis. Where do you think, in which industry do you think silica will a person working will be exposed to silica? The first thing is obviously occupation. These are all occupational lung disease, right? Which industry do you think silica a person will be exposed to silica? Electrical. Anything else? What is silica? Silica is sand, right? Silica is nothing but sand. So glass manufacturing, that's one of the important industry. Glass is made of silica. That's one of the important things where people are exposed to it, right? There is sand blasting. Okay? Sand blasting industries. You have silica exposure for sure. Hard rocks. If you see mining, not only coal, they'll break stones or your mountains to take minerals, right? So hard rock mining will definitely get exposed to silica for sure, right? And off late, the hardcore silicon is different, silica is different. Okay? So the chips, the hardwares, right? Most of the hardware chips are made of silica particles. Hardware manufacturing also is having a problem, right? Stone cutting, mason, metal, there are multiple things, but these are the major things. Glass is important. Quite a few industries use silica as one of the particle in the manufacturing process. Mobile phones, I need chips, I need glass for sure. Silica is there, inherently there, right? And mobile phone definitely will accept that's the biggest industry available for now, right? So this is the most common occupational lung disease throughout the world. Definitely the most common, right? Now let's see silica. Like coal, we have different types of silica also, right? So we have something called as crystalline silica and we have something called as amorphous silica. Okay, types of silica, we divide them into crystalline silica and we have amorphous silica. Word and terms mean everything in medicine and science. What do you mean by amorphous? What do you mean by amorphous? Amorphous. Amorphous. No particular morphology. Crystalline. As the name says, they are like a crystal. Okay. It is a type of pneumoconiosis. Right? Let's take a crystal crystal will have very sharp edges and something amorphous in my hand, right? Let's say I have no particular shape and I have a crystal here. I'm just going to rub them. Which you think will damage my skin more? A crystal will damage my skin more, or an amorphous, no defined shape will damage my skin more? Crystal will definitely damage your skin more, right? So crystalline type of silica is more damaging for me. Crystalline type of silica, one of the important thing for us is quartz. Quartz is a type of silica. Most of your watches, it'll be written quartz. Everywhere I have silica, right? So this is more fibrogenic. Okay, it's definitely more fibrogenic. And amorphous type of silica is there, but it's not that fibrogenic. I'm not saying it's completely normal, not that fibrogenic. Silica, the crystalline type of silica is more damaging for us, and it's of more of a concern. Fine, right? Let's say the pathogenesis is more or less the same. It goes inside, macrophage engulfs, goes to your produces granuloma, non-necrotizing, ends up in fibrosis. Same thing, right? A few clues which are then for silicosis. Silicosis, for some unknown reason, involves upper lobes of lung. It involves upper lobes of lung. Co-workers pneumoconiosis said that it involves lower lobes of lung, but any lobe of the lung can be involved, right? Now let's see if we can arrive to an amazing X-ray finding. You will help me to understand the X-ray finding, right? Put your pens down. If you're writing notes, put your pens down. I'm inhaling silica. It goes to my lung. Okay? Am I right in saying that from lung, it will go to my lymph node? Yes or no? Will it go or not go? It will go to the lymph node for sure. Right? So the person who takes to the lymph node is my lymphatics, and the silica particle goes to the lymph node. It enters the lymph node, enters the capsule via the afferent lymphatics. What is the first space they'll get exposed to? If you remember a B cell's journey, we know the architecture of lymph node and how lymph node works. From the afferent lymphatics, it goes to a space. What is the space called as? What is the space called as? You know the answer. Do you remember subcapsular sinuses? You do? Perfect. So in the subcapsular sinus or in any sinus in my body, who's there? Every sinus in the body has one cell. Who's that? Macrophages, right? So this silica comes into my lymph node. These macrophages will eat them. They'll engulf them. Can the macrophage destroy them? They can't. It's a crystalline silica. Can the silica, once it went into the macrophage, can it damage the membrane of the macrophage? They are crystalline. They are very, very sharp. Can the crystal damage the membrane of macrophage? Possible? Yes. So if the macrophage destroys, will it release free radicals? Because macrophage has lysosomal enzymes which creates reactive oxygen species. Yes. So now, when the silica came into my lymph node throughout the subcapsular sinuses, subcapsular sinus seen throughout the lymph node, right? Throughout the subcapsular sinus, macrophages engulf them. This silica crystal will go and destroy the surface of macrophage, releases reactive oxygen species. So can I say over the period of time, the reactive oxygen species can completely destroy the subcapsular sinus? More and more and more silica, more and more damage, more reactive oxygen species, the entire subcapsular area will be destroyed. Yes, it will cause necrosis in other words, because reactive oxygen species cause necrosis. What's the most common ion in necrosis? What's the most common ion in necrosis? Everything is there in the first 5 chapters of Robbins. That's all. Ion, calcium. So can I say over the period of time, with all this destruction happening, I can have calcification in the subcapsular space? Yes. I'll ask you one more question. This calcification is dystrophic calcification or metastatic calcification? That's dystrophic calcification. It's a damaged tissue, right? Dystrophic. Perfect. So now I just draw a lymph node. This was a lymph node, let's assume. Okay. And this red color is my lymph node substance. And this area between the black is your subcapsular sinus. And in this subcapsular sinus, like we said, it's going to damage because silica reaches there first and it's going to cause calcification. Okay, it's going to cause calcification, right? Entire subcapsular sinus area, because silica entered and reaches my subcapsular sinus, it destroys them, and in the subcapsular sinus area, it causes calcification. We derive to this, right? Let's say I'm taking X-ray of this lymph node. In X-ray, can you see a lymph node? Yes or no? You can't see a lymph node in X-ray, but can you see calcification in X-ray? You can, right? When I take an X-ray of this lymph node, so that comes the second clue for me. Hilar lymph node will have calcification just surrounding the lymph node, which looks like a, for the person who first saw it, for the person it looks like an eggshell. It's an eggshell calcification because only the outer part is calcified. When you touch it, like an egg, the inner part is very soft, normal lymph node, right? This is very, very classical. You see an MCQ with Excel calcification, I want you to think of silicosis. More commonly seen in silicosis, but any pneumoconiosis can have it, but more commonly seen in silicosis because silica is crystalline. It can destroy things more, and that's why it might have an Excel calcification. Fine. Okay. This is about that. That's a second clue for us. Fine. Third, silicosis will have fibrosing nodules in the upper lobes of lung. Upper lobes are more commonly involved than anything else, right? One more clue for us. Silica. Silica is crystalline, right? So if we're going to shine light into a silica particle, can it reflect in multiple directions? Possible, not possible? Possible, right? This reflection of light was used in a type of microscopy when we read amyloid. What is that microscopy called as? What's a microscopy called as? Polarizing microscopy, right? So silica particles under a polarizing microscopy, they will be positively birefringent. Again, don't need not memorize it. It's silica, it's sand. When you go to a beach and you go close to the beach, the sun will be very, very powerful because sun hits the silica sand, reflects and come to your eyes. That's why it's powerful. Silica will reflect light. That's all, as simple as that. Same. In lung also it will reflect light. I'll show an image of polarizing. This is your normal fibrosis. This is what is there in your Robbins. Just for understanding, this is your normal lung on the surrounding. This is a fibrosing silica nodule. It's completely made of collagen, completely fibrous, right? The same silica nodule, when you look at a polarizer, look at this. That's how dense this lung has silica. Every single dot you see here, the bright dot, are all silica particles. Definitely can damage the lung, right? So this is what happens in case of silicosis, is your positively birefringent silica particle. Okay? That's it might damage the entire lung parenchyma in a due course, fine? No, this is lung. You can know it's lung because what is that? Can you see a blood vessel? You can, right? It's not a lymph node. This is lung parenchyma. This also is lung because I'm sure you can see the alveoli in this part, right? In the periphery, you can see an alveoli. That also is lung here, fine? Looks like a starry sky, yeah. We didn't diagnose it first time, right? If you're diagnosed it first time, you can give an appearance of a starry sky appearance. They should have named this starry sky. Ideally, this actually looks like a starry sky more than your Burkitt's lymphoma, right? Okay. Next, when I say silicosis, it's the most common lung disease, and silicosis has different types of clinical manifestation. I have something as insidious onset, 10 to 30 years. It takes time, and that's a commonest time, right? I have something which is accelerated within 10 years. Something is rapid, weeks to months, right? There are three types of clinical syndromes in silica. One thing which is an insidious onset, it'll take lots of time, 10 to 30 years after exposure, and this is the most common subtype. Right? Okay, good. This is what things make you, right? See, you know basic things, no? You can easily you can pass an exam. take, if you don't know something, no, go back to inflammation, immunity. You won't have any disease which will be escaping inflammation or immunity, right? Select an integrin. No one can tell you wrong. It's not required. That's secondary. Here also you can write granuloma formation, interleukins came, TNF came, everything you can write. Right? No one is going to stop you. Right? Insidious. It's burkittioid. Okay. And you have accelerated forms of silicosis. Okay. Accelerated forms of silicosis happens within 10 years of exposure. Third is a very, very rapid onset. Rapid onset is one of the rarest type of silicosis. This happens within weeks to months. No pneumoconiosis happens within weeks to months. It will take some time because it goes there, settles there, destroys and everything, right? Now, I'm going to lead to one more thing. You're going to help me in that as well, right? You have a patient where all the silica particle went into the macrophage hilar lymph node. Uh, External calcification will happen, right? So now, this patient also has a tuberculous bacilli. Do you think the lymph node can process the tuberculous bacilli? Because for TB, the lymph nodes macrophage should present to my T lymphocytes. Only then you'll have a granuloma formation, which is going to destroy them, right? Which will be destroying them, right? So because of this defective functioning of the cells, silicosis actually, I'll answer your question, Sujat. Give me a second. Silicosis increases the risk of TB. The reason is there is reduced cell mediated immunity. Okay? The cell mediated immunity is less. When the cell mediated immunity is less, obviously the risk of tuberculosis is a little bit more. Okay. Sajat, I won't say it's based on the immunity. There are multiple factors here. If you're going to work very closely with silica, very intense exposure might be very rapid. It's more of the exposure than about the immunity. Immunity does play a role, but mostly it's the exposure which plays a role. Most of them will have work for like 9 to 5. Of that 9 to 5, post rapid onset. That's more important. Particles is more important here than the immunity because occupational lung disorder, right? Okay. Because also increases the risk of cancer. Okay, there's an increase of lung cancer also here, right? Okay. This is important. This come in exam. We also know why it increases the risk of tuberculosis, right? That's a second occupation. Where do you think you will have patients with asbestos exposure? Which occupation? Tell whatever comes to your mind. Asbestos. Occupation, right? Because the clue in your question is just based on occupation. Cement factory, good. Right? Cement has lots of asbestos. There are a few things you want to remember. Ship manufacturing and ship wreckyard, where they break the ships. Okay? You won't have asbestosis when you travel in a ship. You won't have asbestosis when you have an asbestos roof on the top. The person who manufactures a roof will have a problem. Right? Cement, yes. Cement's exposure, building construction might result in asbestosis. One of the most important thing is insulation. The insulation, whatever you have insulation, right? They have a little bit amount of asbestos. A person who installs the insulation, removes them or manufactures them, right? They'll have them, right? So whenever I have a completed product, I won't have asbestosis because these are all particles. When I see an insulation or when I see a roof, I will not have asbestos because there's no particles. Unless someone is going to break it and put it into your nose, you won't have a problem, right? So all these at the manufacturing site, when you're going to manufacture the asbestos roof, yes, there's a chance because their particles will be there, right? So insulation industry, cement manufacturing industry, ship manufacturing, wreck yard. You break the ship, it can have particles, can result in asbestosis. Fine. Asbestosis, again, I have two different types of asbestosis. Serpentine type and amphibole type. Serpentine. What do you mean by serpentine? Serpent-like. It's wavy like a serpent. Amphibolus, sharp fibers. These are wavy fibers. Which of these two fibers do you think you can bend to any shape you want, or which is malleable? Serpentine is definitely malleable, right? I can bend to any shape I want. This is sharp, straight. I bend, it breaks. So if I bend a fiber and it breaks, it will not be useful for industries, right? Since this amphibole fibers are not malleable, these amphibole fibers are actually rarely used in industries. These are commonly used in industries. Just because of the nature of the fiber, I commonly use them in industries, right? If I'm going to use them commonly in industries because the malleable nature, again, if the fiber reaches my lung alveoli, am I right in saying that it can again bend and escape the alveoli? Is there a possibility? That is right. The same nature of the malleability, they might escape alveoli. When they escape alveoli, they are more pathogenic or less pathogenic? They're actually less pathogenic. That's good for us. Okay? Very good for us. They are less pathogenic here. Here, they are very rigid fibers. They're actually more pathogenic. Rarely used, more pathogenic, completely fine, right? Okay. See, you should have a very, very strong insight about your clinical history. That's what is going to make your thing great. If whatever specialty you take, if you don't have an understanding of how the patient is going to present, you will not exceed at all. At any point of time, you will not be able to exceed it, right? So what happened is like I have never seen a case of mesothelioma. So when I was in my PG, I told to my professor that a case of mesothelioma I have diagnosed. He asked me what's the age. I told like say 45 years. He didn't even look into the slide. He said you're wrong. 45 years mesothelioma cannot happen because one of the specific disorder what asbestos causes mesothelioma. Mesothelioma needs at least 30 years of your pathogenesis time. In addition to that, 10 years of making it symptomatic. I need 30 to 40 years of pathogenesis. And no person is going to work at 5 years. They start working at, let's say, 20 years. Sixth or seventh decade is where mesothelioma comes. Asbestos to cause any disease, it takes a long, long time. So please don't jump into diagnosis. It's simple. Go and look at the tiny nuances. You will be able to answer the question very easily or solve a case very easily, right? I'm not doing super specialty. This happened when I was in PG. My the person who told this was Dr. Siddharaju. He wrote the foreword for the 10th edition of Robbins. If you have a hard copy, there'll be foreword written. Ninth or 10th, I forgot. Some edition of Robbins, he wrote the foreword for it. Okay. You should have good teachers. Good teachers. I fortunately got good teachers. I'll try to give whatever they taught to me, and you have to transfer whatever you have to your juniors because that's what makes our community strong. And we are strong. We can any day ace any disease, and we can defeat the disease together. Right? Okay. Now let's go to your asbestos spectrum. What all diseases can asbestosis cause? The pathogenesis is same. The pathogen is undoubtedly same. Same, it eats, destroys granuloma fibrosis. The first disease asbestosis causes something called a pleural plaque. What do you mean by plaque? Okay. Thank you, Vijay Tamas. What do you mean by plaque? We know what is plaque. I'm not going to answer it. Plaque. We learned about atherosclerotic plaque. That's why I said it's a plaque. Perfect. That's all. It's irregularity. It's the most common symptom of manifestation of asbestosis. These asbestos fiber, they go and deposit in the pleural space. So on the surface of pleura, it's going to be irregular, as simple as that, right? It happens on the surface of pleura where you'll have just there this collagen accumulation, right? Just dense collagen accumulation. It's simple. You can easily remember them. Imagine a person is inhaling the serpentine fiber of asbestos. It goes to my lung. It goes and keeps on moving, goes outside the lung, goes and scratches the pleura. Scratches the pleura, causes tissue destruction, heals by fibrosis. Fibrose is nothing but collagen deposition. If the collagen is depositing on the surface of the pleura, it makes the pleura irregular. As simple as that, right? It's common in multiple places, but it's said that it's seen mostly in the anterior and posterolateral aspects of pleura. Okay? Lateral aspects of pleura, of parietal pleura. Okay? It causes some irregularity, that's all. It can also be seen on the diaphragm, above the diaphragm also it can see them. This is not a problem for me. They are innocuous, they are not symptomatic at all. They are asymptomatic. Again, that's good for me. They're asymptomatic, but it's having collagen accumulation. If there has been a collagen accumulation, there must have been tissue destruction for sure. If there's tissue destruction, can I say there'll be calcification? Possible. If there's calcification, can I pick them up on X-ray? We can, right? So this is where doctor comes into play. The person working in a manufacturing industry, ship manufacturing or installation manufacturing, has X-rays again on a regular interval based on the exposure of asbestos. If you have pleural calcification, give them a rest. It's reversible. It will come back to normal, right? Okay. It can be picked up on X-ray. You'll have pleural calcifications because these don't cause symptoms. But if I let them spread more and more and more, entire lung pleura is having fibrosis. Can it cause restrictive lung disorder? It will not let it expand, right? It will obviously cause a restrictive lung disorder. And the most common manifestation, early manifestation as well. There's an image from Robbins. There's a base of the pleura. I'm sure you can see this normal. This is a block. It's irregular. Some irregularity is there on the surface of the pleura. It's a postmortem finding, as simple as that, right? It's just doesn't cause your pleural block. It can cause multiple things. It can cause pleural effusion. It goes and irritates the pleura. Obviously, you will have transudation and exudates. It will definitely happen. It will result in interstitial lung disease. This is something which is concerning because if it's interstitial lung disease, Tapasam, the reason why it doesn't look like lung is, like I said, this is the base of lung. Lung, you have like this, right? If you look lungs from here, that's how this looks. I'm looking from the base, it's looking differently. That's all. That's not fat. That's the pleural block here. When I'm having destruction resulting in collagen, little bit of fat also will be there. It's looking yellow in color because it's an inflamed condition. So that's how it looks. Fine. Okay. So interstitial lung disease, again a concern because once this fibrosis happens, it will become irreversible. Not just that, it can also cause cancers. Cancer is the most concerning for me, right? Asbestos can cause multiple types of cancer, not just your lung carcinoma. It can also cause mesotheliomas. It can also cause carcinomas outside the lung. It can cause ovarian tumors. It's supposed to, there are documented evidence that asbestos can relate to colonic cancers as well, right? Not just asbestos, lung related thing. The primary reason here is, like I said, it's a serpentine fiber. They can escape outside, goes into the systemic blood circulation. If it goes and destroys my ovary, it can cause cancer there, right? But predominantly my concern is, if I say the most common carcinoma, I would say lung adenocarcinoma. Okay. If I say most specific carcinoma, it's specific. The word specificity is there. Then it's your pleural mesothelioma. This is important. By incidence, lung adenocarcinoma is way more common than mesothelioma. Mesothelioma is rare, but if you have a patient with mesothelioma, undoubtedly there'll be an exposure to asbestos at some point of time for sure, right? So these are the way of clinical spectrum I can have from a very asymptomatic pleural block to a very deadly disease of cancer. All of them can be seen in asbestos patients, right? Just one more finding here. So what I'm going to see in microscopy, let's say I'm having this tiny tiny asbestos serpentine fibers coming into my alveoli, right? It's coming into the alveoli. Am I right in saying that these fibers, which one, Tabasam? These fibers, like I said, like, it can escape lung for sure, but it's totally based on the quantity, right? It's totally based on the quantity. If there are too many of them, it'll get blocked. Not everyone will escape, right? Some of them will retain there, some of them will escape for sure, right? So here, when I have a serpentine fiber which is stuck in the alveoli, can this serpentine fiber damage the alveoli and cause microhemorrhages? It can, right? Because they're very sharp fibers, wavy but sharp fibers, right? So these fibers can damage the alveoli and they will cause tiny bleeding, tiny areas of bleeding. It's not going to cause pulmonary hemorrhage that severely, tiny areas of bleeding. So when few amount of RBCs come outside, RBCs will be destroyed. Over the period of time, what happens? Once RBCs are destroyed, hemoglobin is there, heme will be reutilized, globin will be reutilized, the iron gets in deposits here. Because of this tiny years hemorrhage, the iron deposits on the surface of fibers over the period of time, a long term. So this is what resulted in this. Look at the color. I'm sure you can see the color, right? It's brown. Brown in color. Yes, it does remove them. Like it's same thing. Like when I have you're falling down, some thorn pricks you, there'll be tiny areas of hemorrhage, right? After that, definitely my macrophage will remove it. It's a process. Macrophage will remove them for sure, but before macrophage removes, I might have tiny areas of hemorrhage. It might go unnoticed, right? So that results in deposition of the iron on the surface of the fiber. Even if you can look at this, there's a macrophage trying to remove them also. So this finding is called an ferruginous body. Actually, ferruginous body and asbestos body are different, but they are interchangeably used in most of the places. They'll use the same, right? Ferruginous body or an asbestos body, right? Okay. So that's what we see in the microscopy of asbestosis, ferruginous body or an asbestos body. I can see them in pleural block. I can see them in lung cancer. I can see them in pleural effusion or an interstitial lung disease. This says there's an asbestos involvement to the disease. This doesn't diagnose lung cancer. I need your adenocarcinoma, glands, and the 4 feet of dysplasia is needed to diagnose lung cancer. Right? Okay, that's about you. Asbestos-related lung damage. Right? That brings us to the end of. Again, this is same thing. What stain do you think this is? Tell me the stain. That same ferruginous body like you saw in the previous image. What stain is this? No, Sajat. False, right? Because it is iron, it is ferruginous. If it's iron stain, it has to be hemocentrin, Pearl's Prussian blue. These are the ferruginous body which have been highlighted in Pearl's Prussian blue. Iron stain. I'm sure you know the iron stain. I think you must have seen Zeal Nielsen's recently in your microbiology, and that's having an impact for you in diagnosis, right? Fine. Okay. That's about few things which I want you to know regarding asbestosis. Let's go to lung tumors. What do you think is the most common lung cancer? See, such as like I said, asthma, I have read all the pathogenesis, taught all the pathogens in your type 1 hypersensitivity, right? Entirely the same thing. It's hypersecretion, same thing. Symptom will be wheezing, that's all. Doesn't change in asthma. Nothing much is required for you in asthma, fine. Adenocarcinoma, more than that, anything else? Okay, Vidhi, a good question. Like I said, when I'm going to take an X-ray, there are factories act required there. And when a person is being put in a work environment, the work environment will be moving here and there. When a person is working in a coal mining, some few parts of the year they may work definitely in coal mining. Then they'll give some other desk job. Then they go like that. So I kind of delay them. I just gave it in coal mining industry, at coal mining. Then yes, I need to take them for sure. Fine. So that's how it is. Yes, I just gave a template of every 6 months, but it can be modified for sure. Fine. Okay, squamous adenosmall cell. We had all the options here. The most common lung cancers. I've told you this before. Metastasis. Mets is most common, more common than any primary lung tumor. In lung, liver, CNS, and in heart, Mets are more common than primary. Then comes your primary lung cancer. Okay. Primary lung cancer, I'll definitely talk about that when we come to primary lung cancer. We'll see most common. I'll ask you one more question same time. Fine. So metastasis, there are few clues for us. You're going to help me to identify the clues. Mets are common in the center of the organ or in the periphery of the organ. If you remember the steps of metastasis, you will be able to easily answer them. Center of the organ or periphery of the organ. Mets are always seen in the periphery. Right? Mets are always seen in the periphery. It will not be seen in the center. The way to remember them is Mets are from skin as well as to go outside to the lung. They will exit only in a capillary. They cannot exit in a pulmonary artery. They get damaged. It's a hemodynamic thing, right? Mets are single or multiple. Mets are single or multiple. Mets are always multiple. Again, same logic, right? Again, same logic. It's multiple because it's moving from one place to another. Why should I fail once and then try? Send 100,000 people, see who is successful, right? Mets are always well defined. They are well defined lesion. That's why lung metastasis in a chest X-ray finding, we have a name called as cannonball secondaries. You must have heard them, right? Cannonball secondary, it's perfect, well defined, or a coin lesion, well defined. Mets, when the metastases are large, you might have central necrosis or central umbilication, right? It can happen large deposits. All these are characteristic of Mets for any organ, be it lung, liver, brain, heart, anywhere, it will be the same. It's an example of metastasis. Image from Robbins, multiple, well defined, periphery of the lung. All these are metastatic foci. And the most common primary for lung metastasis is breast cancer. Most common primary is going to be from breast cancer, right? So this is about lung metastasis. Okay? Maths are not that important for from an exam point of view, but I just want you to know any question comes most common, I want to think of metastasis. Okay, let's go to lung primary now. What do you think is the common cause of lung cancer? Common cause of any lung cancer for that matter, whatever cause you know, you can tell. Whatever you think, it comes back to smoking only. Cigarettes only is the commonest cause of lung cancer, right? We generally look at medicine from a textbook point of view. You're very young. I don't want you to look at medicine from a textbook point of view at all. Textbook gives me information. Experience gives me medicine. Medicine is a way of life. Medicine is not to be learned from textbook. Medicine should be interlinked with multiple points in daily things what we see, right? So if you look at the medicine textbooks, if I talk like 10, 15 years back, it is written in that most common cancer is squamous cell carcinoma of lung. The recent textbooks say that the most common cancer is adenocarcinoma of lung. It changed. It will not change without some change in the etiology. I have to look at what changed the etiology and how I have to tackle them. Because tobacco companies are very, very powerful. They are very, very rich. Right? They are extremely rich. Uh, you know how rich they are? ITC is International Tobacco Conglomerate, right? ITC, all the five-star hotels are tobacco money. Faber Castle, Classmate notebooks. Lucknow Super Giants also sponsored by them, I think. That's how big they are. They're huge. They have a research grant, which research grant of ITC, that's to research on how to improve smoking, is bigger than the research grant for most of the aims in our country. Unfortunate but true. So in the mid of 1980s or 1990s, what happened was they wanted to increase the smokers' experience of smoke. What do you think is the commonest problem in smoke? And you need not be a smoker to know that. When a person smokes, the first thing is they will cough. So tobacco company said that how do I make sure cough will not happen? If a person doesn't cough, it smokes smoothly. User experience increases, right? Filter. They researched. Smoking companies knows particle size. They put a filter, and when the filter is put, all the bigger particle size will be held by the filter. Which means everything more than 5 micron is the only one which will be caught up in cilia, which is the only one which will trigger smoke. They put a filter so that all the 5 micron particles will stay back in the cigarette butt. Only rest goes inside. So no cough. Increase the user experience. People started smoking, which is non-filtered smoke. Which smoke doesn't have filter? Or which cigarette doesn't have a filter? BD doesn't have a filter, right? Nowadays, BD is very less. Circulation might be there in few places, but overall, when you look at any place you go, filtered cigarettes are definitely replacing BDs over the period of time. I'll tell you why it replaces also very soon. So when it filter happened, so the particles is reduced. When particles is reduced, where do you think now smoke particles are getting deposited after filter? In the bronchus or in the alveoli? Where do you think they're getting deposited? They're getting deposited in the alveoli. It irritates the alveoli. When it irritates the alveoli, it produces a cancer like the shape of an alveoli. What is the shape of an alveoli? Round. It produces a cancer which is adenocarcinoma. When BD was predominantly used, let's say 20, 30 years back, where do you think the particle size must have settled? Bronchus or alveoli? It settled in the bronchus. It caused squamous metaplasia. What carcinoma it caused? Squamous cell carcinoma. One filter changed the dynamics of cancer. That's why I said medicine should not be read from textbooks. Medicine should be read from real life. I'll tell you, people are amazing. There are few people in every segment who are amazing. When India decided to put more tax on BD, that's a time BD reduced in circulation, because 30 years or 40 years back, there must have been an amazing epidemiologist who told to my government, see, my people are smoking and they're having cancer, please stop that. And the only way to stop any consumption is increase the cost. BD now also has more tax than a filtered cigarette. But somewhere down the lane, I got disconnected. I'm focusing on textbook and exams. I don't have an epidemiologist now to tell to my country, put heavy tax on cigarettes with filter smoke also. It happened in last budget also. The cigarette tax increased. It will increase. It should increase. The only way to stop smoking is government intervention by making sure one cigarette costs 150 rupees. People will stop smoking. Because you have to understand, economics is more important than pleasure. Only when you have money you will smoke, right? New Zealand is a country where a pack of cigarette is more expensive than a dinner. I hope my country, one point of time, slowly will go to the direction. If it goes in that direction, I know for sure I have a doctor who is knowledgeable, goes and is telling my government what to do, and my government is doing that. My government did that 40, 50 years back. Some good doctor did that. So BD went out of circulation. Squamous cell carcinoma reduced in incidence after 30 years. When you make a change today, it will not be seen today. When you read good quality textbooks, it will not reflect in your exams. It will reflect 20 years down the lane when you want to see a patient. Struggle, no, it's fine. It's medicine, you have to love it. Don't go for shortcuts. Please don't go for shortcuts. Shortcuts will give instantaneous pleasure. Anything which comes easy will go easily, right? So that's how important what a smoking changed the epidemiology and the cancer risk. Now what's happening is squamous cell carcinoma is very less. Adenocarcinoma is increasing. Adenocarcinoma is the most common in the world. It's most common in non-smokers, most common in smokers, most common in India, most common in men, women, everywhere, because smoking habit changed. And all of them are actually in Robbins. Whatever I told is there in one line of Robbins. Take from that line and extrapolate. That's what is going to make you great. Now, whatever I said, if see, whenever I say something, don't believe me outrightly. I could have bluffed, right? Definitely, I could have bluffed. To make it sound interesting, I could have bluffed. Take it from me. Whenever anyone teaches anything from you, I want you to verify. Don't take it from face value of any teacher on earth, because you're going to be there using my or any teacher's concepts to diagnose and treat a patient. So I want you to be doubly sure of whatever any teacher teaches. There should be we are reading evidence-based medicine. So whatever I told is right, I'll show you the evidence also. It will happen. If whatever I said is right, squamous cell carcinoma will behave in a different way. Adenocarcinoma will behave in a different way, right? Let's see if it's right or not. Etiology of squamous cell carcinoma predominantly is an crude variant of smoke. Instead of writing unfiltered variant, I'm just writing in crude variant of smoke. If it's a crude variant of smoke, it settles in the bronchus. like I said, or the larger areas. Once it settles in the bronchus, it causes squamous metaplasia. When it causes squamous metaplasia, which is ideally reversible, but it became irreversible if the person is going to keep on continuous smoke, it will result in dysplasia. Once it results in dysplasia, it results in carcinoma. This is what I was speaking for the last couple of minutes, right? If this is true, tell me, where will you see squamous cell cancer? In the center close to the hilum or in the periphery close to the lung? Where will you see squamous cell carcinoma? Center or periphery? You should see them in the you see them in the center, right? Because it's settling in my bronchus. When I say it's settling in the bronchus, this is where it is. I should have seen a cancer somewhere here, right? Somewhere here. Because only a fine variant of smoke will go and stay here, will irritate here, causes cancer here, right? I hope Sajjad and Vidhi you understood that, right? A crude variant so settles in the center, creates metaplasia, creates a carcinoma. That's how it will look like. I'll show you a squamous cell carcinoma image. What is this? I'm sure you can identify the structure. What is that? Can you see the rings, the bronchial cartilage rings, right? That's a bronchus. And you can see the cancer is close to my bronchus. Squamous cell carcinomas are central lesions. So whatever I told is right. I need an evidence. Without evidence, don't believe anyone in the world, right? Because we are going to read evidence-based medicine. I need evidence for whatever we teach. They happen due to crude variant of smoke only. That's why it reduced over the period of time. Yes, I do have one more component also, which is mutations. Mutations in squamous cell carcinoma is not that common for me, but in adenocarcinoma is very important. I'll tell you why as well. I can have multiple mutations. You can have 17p loss, 9p loss, 3p loss, multiple things, right? You can have involvement of 3p, you can have involvement of 9p and 17p. You can have mutations in any of them. Like I said, it's not that important. Yes, it contributes to the cancer. That's all. It's not one of the important reasons. It contributes to the cancer for sure, right? So once this happens, there are few features which I want you to remember for every squamous cell carcinoma. One, like we just now saw, they are central or hilar lesions. Yeah, our bronchus here, it starts growing from here. Which one, Atul? This one you're talking about? It's spreading from here. The cancer, right? It can grow. It can grow for sure. It's spreading from the area. Origin is always from the center. Right? That's what I was coming for the next point. So if it's in the bronchus, I have a hollow area, right? I have a hollow area. Can it grow bigger? Is there a possibility for it to grow bigger and bigger and bigger? Because I have space for growth since it's arising from the bronchus. It will, right? So when it grows bigger and bigger and bigger and bigger, what do you think will happen to the blood supply to the center of the lesion? Because growing, expanding in the periphery, center of the lesion, what do you think will happen? Can I say it will be reduced? It will be. So is there a possibility I might end up in having central necrosis? It's again possible because they are large lesions. As compared to adenocarcinoma, they are large lesions because adenocarcinoma happens in the periphery. Very little space for me to grow, but here it will grow bigger and can destroy it, right? If I'm having central necrosis, let's assume I'm taking an X-ray. The necrotic area is dead tissue. Can I see them like a cavity in X-ray? Again, one more important finding. Cavity on an X-ray. I would say this one, the only cancer which presents as chest cavity. Most of them, X-ray cavity, I'll think of tuberculosis. Yeah. Cancer options, and in chest X-ray you have cavity, think of squamous cell carcinoma, most likely, right? Fourth, see, everything here is with C. Central lesion, central necrosis, cavity on X-ray. Fourth is also C. One of the classical paraneoplastic syndrome, hypercalcemia. Okay, hypercalcemia is one of the classical. I'm writing PNS for paraneoplastic syndrome. I hope you remember paraneoplastic syndrome, what we read in neoplasia chapter. This could be one of the presenting symptoms for squamous cell carcinoma, right? It's due to smoking related cancer. All of them are true. Let's say the patient has cancer, which is there in the bronchus. What do you think is the most likely symptom here? What do you think is the most likely symptom here? Can I say cough? Something is there in the bronchus. From starting point, symptomatology is, for most of the cancer, symptomatology is more or less the same. Cough will be there. When the lesion grows, you might have hemoptysis. These are the common symptoms. Hemoptysis is blood in the sputum. Most of the time, cough and hemoptysis is one of the common symptoms. There was some difficulty in breathing. I won't put much forward because these are very slow growing lesions. Every cancer takes like 10-15 years to grow. By the time it's going to destroy the lung, my lung will adapt, the opposite lung will be able to take care of it. Unless it's sudden, respiratory difficulty is not the most common finding. But yes, it can happen. It can also happen, but not the most common one, right? Okay. Squamous cell carcinoma or even adenocarcinoma for that matter has something called as Horner syndrome. This happens with respect to, I'm not saying it's a squamous cell carcinoma, with respect to any apical tumors. When you have tumor in the apex of the lung, this apical tumors can be squamous or adeno. Anything. It's about apical tumors, that's all. This will compress the cervical sympathetic chain. I'm sure you must have heard about Horner syndrome in your anatomy itself. You're asking why meds are more common, Sajay? If you remember your anatomy, Horner syndrome is something you must have read. Okay, I'll tell you. I'll give me some time. I'll tell. If the cervical sympathetic chain is obstructed or being destroyed, how do you think the patient will present with? There are few classical symptoms of Horner syndrome. What are they? You might have ptosis of the eye, meiosis, and one side of the face will have loss of blood, loss of sweating, anhidrosis. Right? Perfect. Ptosis. The same thing what you read in your anatomy. Same. Ptosis can be there. You can have meiosis and you have anhidrosis. Anhidrosis is loss of sweat in the face, right? Because the sympathetic chain is gone, it's in the apex. It goes compressed here and causes problems in the face. That could be one of the symptoms, especially in an essay question. If I want to divert from lung cancer, I can give you symptoms of Horner syndrome and ask you to rate what it is, right? And all these tumors which cause Horner syndrome, they were given a term called as Pancoast tumor. It can be squamous or adeno. It should be in the apex, that's all. See, Sajad, meds are more common for a simple reason. Lung and liver are the organs which has quite a good amount of blood supply. So any cancer which goes into the blood is more likely they can go and deposit in the lung because of its extensive blood supply. Same with liver. Extensive blood supply, especially GI cancers, will definitely go into the portal system for sure, right? That's why these have more chance of having metastasis. The microscopy, I'm not going to tell you. What's the pattern? You're seeing here also same pattern. Same thing. The pattern for any squamous cell carcinoma is keratin pearl plus the four features of dysplasia. I'll not repeat the four features of dysplasia. Liver. The four features of dysplasia are your pleomorphism, high NC ratio, mitosis, and loss of polarity. Right? All the four features of dysplasia will be seen for any cancer for that matter. Right? So just to complete immunohistochemistry, remember these two markers P40 or P63, not 53, 63. Right? P40 and P63, these two are markers for any squamous tumor, which means esophageal, skin, vulval, vaginal, cervical, anal canal. Any squamous cell carcinoma throughout the body will have the same microscopic keratin pearl, will have the same immunohistochemical marker P40 and P63, right? As for entire squamous origin, not just for lung squamous cell carcinoma. Okay, that's about squamous cell carcinoma. Let's have a look at adenocarcinoma. For adenocarcinoma, this is the most common carcinoma in the world, in India, in men, in women, in smokers, and non-smoker. I'll tell you how non-smoker also has adenocarcinoma more commonly. Everywhere, the most common carcinoma now is adenocarcinoma. Etiopathogens of adenocarcinoma, one is your fine variant of smoke. Whenever there's fine minute of smoke, it goes till the alveoli. It irritates the alveoli and forms lesion, which is like an alveoli, which is gland forming lesion. Such as same answer what Tabasam said. Cor pulmonale due to lung cancer is bit unlikely because for me to destroy the entire lung, such a huge tumor, by the time cancer would have killed the patient. Right? So it's very, very unlikely to have a cor pulmonale. It produces in microscopy, it produces glands. When you have a glandular microscopy, I'm going to call it an adenocarcinoma. Okay, that's for fine variant of smoke. For smokers, how they have adenocarcinoma, right? At the same time, non-smoker also has adenocarcinoma. They are unfortunate, but yes, I had a friend's cousin, 34-year-old non-smoker adenocarcinoma with metastasis. Difficult, very, very difficult. We lost her. Couldn't do anything because it's aggressive. Unfortunately, it's aggressive. It's not about passive smoking. Here, the passive smoking doesn't even matter because passive smoker is not going to result in cancer. You won't every day you won't inhale passive smoking, right? I take two structures here. One is bronchus, one is alveoli. Which you think is very flimsy or which can be easily destroyed? Bronchus or alveoli? Obviously, alveoli, right? Alveoli is very, very subtle, it can be easily destroyed. So, when something is getting destroyed, am I right in saying that it will regenerate? It will obviously regenerate. So, once it regenerates again, destroyed again, regeneration, destroyed, regeneration. If it keeps on having this cycle of destruction and regeneration, is there a possibility of a mutation? Yes. Since alveoli, in alveoli, there's lots of or increased cell turnover. When there's cell turnover, again I'm saying there's a possibility of a mutation. So in non-smokers, the cancers are generally due to mutations. Okay, I'm not saying everyone will have cancer. It's unfortunate. Unfortunate they are having a mutation, and there are three mutations which I want you to remember: EGFR, the most common mutation seen in Asians, and they have a very very good prognosis. EGFR mutation can have a good prognosis. KRAS, KRAS mutation has the worst prognosis because you can't give any targeted therapy. Chemotherapy also will be very, very resistant. And ALK1. I want you to remember all these three because as on today, if I have a patient with coming to me with lung adenocarcinoma, I have to do all these three if the person is affordable. Only then treatment starts. So I know that surgical surgeon knows that, medical oncologists and medical people know that. So if I am doing it in practice, it might come for you in exams, right? So you might have many other mutations. Your Robbins also gives an n number of mutations. I don't want you to remember everything. This please don't forget because these three are very important. One, that's how I'm going to diagnose your adenocarcinoma. So all these three are very very important. Don't forget this, right? So most of the adenocarcinoma happening in the periphery are due to mutation related in non-smokers, and in smoker we know the root for sure, right? Now, when you take adenocarcinoma in general, we have kind of three broader divisions. The first thing is called an atypical adenomatous hyperplasia. If you remember the cancer chapter which we read in the neoplasia chapter, we saw about CAN1, 2, and CAN3. Right? Progression, same way this is. Atypical adenomatous hyperplasia, they are less than or equal to 5 millimeter in size. Do you think a 5 less than 5 millimeter, this tiny, do you think they'll cause any symptom? They don't cause symptom, right? They are asymptomatic. Most of them are diagnosed incidentally. There's actually overdiagnosis. Why this came into existence is CT scans have been stored for 10-15 years in computer. No one is going to delete them. So if someone has cancer like 20 years down the road, they'll go and see all the CT scan taken. And they'll tell the radiologist, see, you missed the 0.5 millimeter lesion. That's why it became cancer. You should have diagnosed it here. All these consumers protection is making us to diagnose over. The microscopy, I'll say few dysplastic cells. I don't know what is few dysplastic cells. There are few dysplastic cells. Why should I worry? Report it. WHO says that if there's an atypical adenomatous hyperplasia, take an HRCT every 2 years. You take HRCT every 2 years, that itself will cause cancer, like Vidhi said. Then they will say, see, I told you it will cause cancer. This is overdiagnosis. Unfortunate, but I have to do it because of consumer protection. Everything is being stored for a longer time. So I'm trying to diagnose them much, much, much early. This might not, should not have happened, but I can't do anything, right? Next, it progresses to second stage cause an adenocarcinoma in situ. What is the main difference between in situ and an invasive adenocarcinoma? These are lesions of 5 millimeter to 3 centimeter. They are symptomatic. 3 centimeters definitely symptomatic, right? They'll have symptoms. This, yes, I have to identify them, I have to treat them. What's the main difference between basement membrane invasion? That's all, right? It's basement membrane invasion. Here, there's no invasion of alveolar membrane. Okay? No invasion of alveolar membrane here, which means how it looks in microscopy is, let's assume this is my alveoli. I have tumors here. I have tumor cells, dysplastic tumor cells. That's where lining the alveoli. It will not go into interstitium. It will not invade. That's why there's no invasion here, right? So this was given one more name just for understanding. It was given a name for some random person. This is how it looks in microscopy. There's no invasion, but I'll have dysplastic cells lining the epithelium completely. For some random person, he said that when I cut it and I made them look like this, the cells are like this. So for some person, the cells look like birds sitting on a line. I don't know why they want to do that, but this has a name or a pattern called as lepidic pattern. Lepidic means birds sitting on a line. Either the guy should have been extremely, extremely imaginative, or most of the time it's due to LSD. Because no one is going to look at the microscopy and say, cut the alveoli, make it a straight line, and imagine birds sitting on it, right? He must have smoked up something and named a pattern, and unfortunately we have to read that pattern, right? So lepidic pattern is nothing but it's uniformly seen on the surface of the alveolar membrane, which is seen in adenocarcinoma in situ. The next thing is only one, is an invasive adenocarcinoma. The only difference between in situ and invasion is basement membrane invasion. Here, basement membrane invasion is present, is seen any size. It doesn't matter. Even if it's 1 centimeter, having invasion, it's an invasive adenocarcinoma. So microscopy, I'll have glands plus 4 feet of dysplasia. That's how every adenocarcinoma look like. And invasion, obviously. So IHC for this for entire adenocarcinoma, be it in situ, be it atypical, or be it adenocarcinoma, all of them has the same IHC, napsin A and TTF1. See, this might be new for you, so I want you to read with your friends. TTF1 and napsin A is a diagnostic thing for adenocarcinomas. Fine. Primary lung adenocarcinoma, not for any other adenocarcinoma, only for lung adenocarcinoma. Fine. This is an image from a pulmonary pathology website, periphery. Atul, if you're there, I hope you can identify the difference between this periphery and this periphery. Here, it's coming from this side. It's coming from the bronchus and extending to the periphery. But if you look at this adenocarcinoma, there's no connection. It's there in the periphery alone, right? So they are peripheral lesions. That's why it reiterates the thing saying that it's due to fine smoke coming to the periphery and they are irregular. And if you look at the microscopy, glands. You have glands, you have glandular morphology, definitely high dense ratio. You can see that the extremely blue cells, right? Pleomorphism, everything is there. Instead of saying invasion is present or not present, there's an easier way. If you see desmoplasia, which is nothing but fibrosis, if you see the glands are being separated by pink color fibrous tissue, I know for a fact that invasion will be present, right? If desmoplasia is present, which means between glands, there's pink collagen tissue or pink fibrotic tissue, which means invasion has happened and it's an invasive adenocarcinoma. This is the main difference between this and in situ. In situ, you won't have the pink fibers separating the glands. It'll be back-to-back arranged glands and no fibrosis. In situ, with this invasion, you'll have your fibrous tissue there. Fine. That's about adenocarcinomas. Now look at neuroendocrine tumors. So neuroendocrine tumors, I have broadly classified them into three groups: carcinoid, atypical carcinoid, and small cell carcinoma. All these three are under neuroendocrine tumors, right? Remember one thing, neuroendocrine tumors, all these three, okay, all of them are malignant. Carcinoid is a low grade malignancy. Small cell carcinoma is the most aggressive malignancy there. Can anyone tell me what is the neuroendocrine cell in lung or in the bronchus? Have you heard about a cell called as Kulchinsky cell? You might have, right? So origin for all these neuroendocrine tumors is from a cell called as Kulchinsky cell. That's a neuroendocrine cell from where only all these neuroendocrine tumors comes, and all these three are malignant tumors only. Carcinoid is a low grade malignancy. Okay, atypical is an intermediate, and small cell carcinoma is the most aggressive lung cancer known to us. Okay. Let's look at carcinoid and small cell atypical carcinoid first. The difference is based on microscopy. Few pointers from the gross also might help. Carcinoid, can anyone tell me what is the pattern for carcinoid, if you remember? Any pattern for carcinoid? If you remember patterns of neoplasia, any pattern for carcinoid? No. The carcinoid has nesting pattern. Nesting or an organoid pattern. I'm sure you must have read them, right? Nesting or organoid pattern. Atypical carcinoid will not have a pattern, and small cell carcinoma, if you remember pattern, it has something called an Aso-Party effect, right? Okay. So carcinoid here, it's a low grade malignancy. This intermediate grade malignancy. Carcinoid has a very characteristic gross finding. Both of them happens in the bronchial mucosa, right? Carcinoid especially grows in endobronchial growth. Let's say this is bronchus here. I'm having your bronchial mucosa. It grows like a button. It grows here tiny. There's a connection from the outside. So it kind of looks like a collar button. It grows like this, like a dumbbell-like mass. It can go inside. Tumors in enclosed space. That's what the nesting pattern is, right? So it has one more classical name called as a collar button lesion. Okay? Collar button lesion is a classical findings in a carcinoid. Here, there are also central lesions, but there's no particular shape or nothing like that, not like a button. It's there. It's a tumor seen in the central space. That's all. Close to the hilum, it's seen. Carcinoid in microscopy, like I said, there's a pattern. There's a nesting pattern here. Atypical carcinoid, there's no particular pattern. It's just tumor cell arranged in sheets or masses. Carcinoid cell is a low-grade malignancy, right? So they have less pleomorphism, no necrosis. Low-grade tumors don't have necrosis, right? ARF is acute renal failure. What does ARF stand for? Yeah, they are a little bit more pleomorphic, and necrosis may or may not be present. Okay, but these are all subjective, right? You might say we see McCallum's block, or we might have vegetations. I'm not sure if the term collar button is used. Verrucae or vegetations can be seen in acute rheumatic fever. So these are very subjective finding. What makes them clear cut say, okay, this carcinoid and this and atypical carcinoid is mitosis. They have mitotic count of less than 2 per 10. HPF stands for high power field, and this is between 2 to 10 per high power field. Less than 2, I call it a typical carcinoid. Very low mitosis count, very low grade tumor, and more than 2, it's an atypical carcinoid, right? Okay. This is an image. I think I use the same image in your patterns of neoplasia also. I think that's nesting or an organoid pattern enclosed in a confined space. Okay. Okay. Okay, the fish mouth appearance. Yeah. If you are saying that, yes, it has in chronic rheumatic heart disease has the fish mouth or the buttonhole appearance. Fine. Okay, Cesar. It's called as a nesting pattern or an organoid pattern. There's one more important finding. Why do I call them neuroendocrine? We'll derive to the finding. Can I say all these cells secrete in response to some stimuli? That's why I call them neuroendocrine, right? They are neuroendocrine. So if the cell is going to secrete serotonin, histamine, or something of that sort, the nucleus should be active or inactive. The nucleus should be very, very active, right? So can I say the nucleus of this patient should have uh, your euchromatin and heterochromatin? They should have both U and heterochromatin, right? So if you have something with both U and heterochromatin, can I say the nucleus kind of looks like this? Let's say this is my nuclei, blue color, euchromatin and heterochromatin. It looks like this. You would have named this also Starry Sky, but the person who first saw it didn't name it Starry Sky. It's a mixture of U and heterochromatin. Euchromatin is a little bit open and heterochromatin is a little bit blue. The person who called this called it an salt and pepper appearance. It's a mixture of U and heterochromatin, that's all. Okay. For a salt and pepper appearance, that's a very, very classical finding for every neuroendocrine tumor seen in mankind. Not just for small cell carcinoma or carcinoid. Let's take insulinoma, neuroendocrine, gastrinoma, neuroendocrine. It'll have salt and pepper appearance. Look at this. Can I just appreciate? It's not completely blue in color. I do a little bit of clear area. If you can see them, I do have clear area, dark area, clear area, dark area. The nuclei. That's salt and pepper chromatin or salt and pepper nuclei as diagnostic of every neuroendocrine tumor, not just seen in carcinoma, right? Remember this for every neuroendocrine tumor known to us, fine? The IHC, yeah, some dot likes. The IHC, what I'm going to say, is also classical for every neuroendocrine tumor. Synaptophysin. We'll stick to two IHCs now. I might add on when we go to different neuroendocrine tumor. Fine. Synaptophysin is a neuroendocrine tumor, marker, and chromogranin. This is also seen in small cell carcinoma of lung. It's seen in small cell carcinoma of lung and carcinoid as well as atypical carcinoma or any neuroendocrine tumor for the matter. Pheochromocytoma, positive. The light microscopy itself is difficult, right? So if you use electron microscopy, it will never end. In electron microscopy, also the same thing, neurosecretory granules. That's all. And the book will have second volume, a third volume. We don't want that, right? That's why it's simple. Okay. Small cell carcinoma as the most aggressive lung cancer. Small cell carcinoma is like close to 100% associated with smoking. It said that if a patient is saying they didn't smoke and you see small cell carcinoma in the patient is lying. It's almost always seen in smokers only, right? Small cell carcinomas mutation are common in small cell carcinomas, though it's not diagnostic for me. P53 mutation will be there and also retinoblastoma mutation. Makes them definitely aggressive and the worst prognosis. Whenever P53 is gone, you're going to end up in a very worst activity, right? So clinically, small cell carcinoma can come in an exam. The only reason they have classical paraneoplastic syndrome. Can anyone name any one paraneoplastic syndrome in small cell carcinoma? I'll write the paraneoplastic syndrome soon. Anyone? You have sheets of small round blue cells, and the effect in small cell carcinomas, Azopardi effect. Not even one. Azopardi effect is you'll have DNA around the blood vessel. You have smudged DNA around the vessel. That's called an Azopardi effect. Fine. Okay. Small cell carcinoma can have Cushing syndrome. They present with Cushing syndrome. They don't present with any lung symptoms. Small cell carcinoma also can present as SAADH. Perfect. So I can have a very unique clinical history. 45-year-old person, obese individual with a moon-like phases. You will think of Cushing syndrome. And subtle finding will be seen there. Hemoptysis present. So they want, what will be the diagnosis? Diagnosis not Cushing's. Diagnosis small cell carcinoma of lung, indirectly causing Cushing's, right? So you might miss them in a theory question. Because for you in the long answer, 10 mark questions, you generally have a clinical history, right? Lambert-Eaton syndrome can also be there. Right? Again, these are common. It can cause an n number of syndromes. Lambert-Eaton can be there. You can have your multiple syndromes. One of these are there. White Scott small cells. Appearance. They're all tiny, tiny, small round blue cells. Right? Any cell which is having this tiny appearance, we call them a small cell carcinoma. That's all. Sheets of small cell. The older name was actually oat cell carcinoma because they look like oats. They are a bit elongated. They look like oat particles. We don't use them anymore. It's small cell carcinoma of lung only. IHC is same like your other things, synaptophysin and chromogranum, right? And this is your azopathy effect surrounding your blood vessel. Surrounding vessel, you have your smudged DNA material, right? The smudged DNA material surrounding the vessel is your azopathy effect for the matter. Right? Okay, this we already saw in your lectures, in your patterns of neoplasias. Well, it's a very, very highly aggressive tumor. One more point in microscopy. What is the number of mutations in atypical carcinoid? 2 to 10. There will be more than 10 certain hyperfield. More than 10, I can definitely call it an aggressive tumor and small cell carcinoma, right? When you look at the prognosis, the best prognosis, it's actually like a kind of becoming like competition. What's happened is adenocarcinoma over the period of time is having a better and better prognosis because of more and more research going into it, more and more targeted therapy coming into it, right? Then becomes a squamous cell carcinoma, then the small cell carcinoma. Small cell carcinoma is obviously worst prognosis of all. This is still contemplated based on the availability of healthcare. If you're in a peripheral place, you don't have good access to chemotherapy or the modern drugs available, then squamous cell carcinoma is decent compared to adenocarcinoma. But if you have good access to healthcare, adenocarcinoma presents better. Most of the cancers is rare. At this I'm talking about prognosis. Most of the cancers is not that common. Small cell carcinoma, adenocarcinoma is common. Then comes squamous. As of now, small cell carcinoma is the third, maybe. Fine. Okay. Just a few words about large cell carcinoma of lung. The reason why I want to include this is there in WC classification. Large cell carcinoma has now been replaced as undifferentiated carcinoma. Okay? Yeah, undifferentiated carcinoma, they're not called as large cell anymore. Previously, they thought that it's a part of neuroendocrine tumor. Now they know that it's not a part of neuroendocrine tumor. It's not differentiated. I know it's a carcinoma, but it's not differentiated at all. It will not have your organoid pattern or a nesting pattern. In microscopy, I'll have feeds of pleomorphic large tumor cells. If at all, if it comes in exam, the best way to diagnose is a tumor with sheets of cell negative for P40, P63. So it's not squamous. Negative for your adenocarcinoma, TTF1 napsin A, not that also, right? So something like a small cell but larger size, right? So it's mostly diagnosis of exclusion. It won't come in an exam. Just to complete it, since they're in Robbins, it's an undifferentiated tumor with good amount of big cells, negative for all squamous markers and adenocarcinoma markers. Fine. That's all regarding your lung cancers in general. Fine. We completed the lung cancers. We did about respiratory restrictive disorders, the pneumoconiosis, and also we saw about chronic bronchitis. Fine. We'll call it a day. Large cell, see, I wouldn't put in the spectrum of small. It'll be small is the worst. Maybe between your squamous cell carcinoma and your small cell carcinoma, we can put it. Since it's undifferentiated, most of the undifferentiated cancer, I give a very high dose chemotherapy because I don't know how to treat. I give a high dose chemotherapy and it will definitely kill them. Sajad, I know that you told. Give me some time. I'll discuss with the other teachers and I'll let you know. Fine. For everyone, is 6 o'clock better? Is 6 o'clock better? If you can give me a thing, I'll be able to implement it if possible. No. So that if you're in hostel, I think you get easily to go to hostel. Like if it's a day scholar, after the college for them, it needs some more time to go there. That's why we kept it at 7 o'clock in general, so that it will not affect others. We'll see what best can be done, Sajad. Fine. No more doubts. If there are no more doubts, we'll call it a day. Just do one thing. Put your headphones. I think you see in laptop, right? Or just for the time, put your headphones. Take the food, sit there and watch. Okay. I know I have no other options, Sajad. Sorry for that. Thank you. Good night.